Go ahead, Dr. Schwartz.
Okay, so you can see that okay?
Yep, we're good.
Okay, so thanks very much. Um, I'm going to talk, you all can interrupt me if there's things that I'm saying that aren't, to clarify things, and then I guess we'll have a Q&A at the end. Um, we've been interested in psychiatric advance directives since they came on the scene in the late 1990s. And I'll talk a little bit about the background and how we got interested. But one reason we got interested in is that we had been involved in studying the effectiveness of involuntary outpatient commitment, or what's called assisted outpatient treatment in some places. And we had done a number of evaluations of it, and particularly had conducted a randomized trial in North Carolina, and also evaluated the largest system of AOT in New York. And when people started talking about psychiatric advance directives as maybe an alternative to using involuntary outpatient commitment, we got interested in how they might work and how they might spread. So that's part of where we came from. So we'll talk something about the potential benefits of psychiatric advance directives, talk about where they came for, the origins and rationale, and then discuss some of the approaches to overcoming barriers to implementation of psychiatric advance directives. And I've tried to learn a bit about Wisconsin, so I'll try to make my remarks specific to you. But Wisconsin is one of the states that doesn't have what's called a sort of a psychiatric directive or a standalone psychiatric advance directive law. So you're a little bit different than some of the states that do. Um, so what are they? We'll call them PADs just to save airspace. And they're legal documents that allow persons when of sound mind, and that's a term that's used in wills and other types of testamentary capacity, to refuse or give consent to future psychiatric treatment. And in many states, those are called advance instructions. You don't have that. What you have is a declaration to physicians, but in Wisconsin, that declaration to physicians really relates only to end-of-life care and isn't really relevant to this conversation. Then the other part of a PAD is what's called a healthcare power of attorney, or in Wisconsin, what's called a power of attorney for healthcare, which allows one to authorize another person to make future decisions on about mental health care in behalf of a mentally ill person, should they become incapacitated. So if a person becomes incapacitated, it allows another person who's been designated in advance to step in and make decisions on behalf of that person. Some of the benefits of PADS is that it allows permission to consult with the family in the role of the healthcare agent. So it gives explicit permission for providers to physicians to speak to a family member. And sometimes confidentiality, or what's perceived to be confidentiality rules, or what's perceived to be HIPAA, prevents conversations with family. And what this does is it gives explicit permission to consult with a family member or to a physician or someone else in the role of a healthcare agent. It authorizes permission to speak with other providers. It can provide a history and a crisis plan via the advanced instructions, if there's an advanced instruction plan, or informs the healthcare agent to speak to that. And in most states, authorizes a hospital admission by a healthcare agent. In Wisconsin, it does not. The goals of advanced directives are to ensure that patients are treated according to their wishes, even when they can't speak for themselves. And for so many folks who have mental illness, the fact that they can't still direct their care or can't be assured that a treatment plan will be carried out when they can't speak for themselves coherently is a real problem. And what this can do is provide continuity. So a person, even when they're not able to speak for themselves, they know that a treatment plan will be expressed. So it provides a mechanism when a person can't speak coherently for an exchange of information. So we'll give clinical information to the treatment team and also can give consent or refusal of treatment. And most important in your case, appoints a proxy decision maker, which is called a healthcare agent, when the patient is incapacitated. So where did all this come from? What's the legal origins of advance directives? Well, they're relatively recent. If you go back to 1990, it arose in the case of a Supreme Court decision called Cruzan versus the director of the Missouri Department of Health. And Nancy Cruzan was a young woman who was in a severe persistent vegetative state. She could not speak. She was being kept alive by artificial means. And her family was very distressed by this and said that Nancy would never want to live like this and asked the hospital to take her off life support. And the hospital said, well, we don't have the authority to do that. The Department of Health of Missouri said, well, we're not going to do that. We don't have the authority to do that. And the family appealed this until eventually it went to the US Supreme Court. And they said, and the question was, does a person have a right to self-determination, even if that act of self-determination would mean that their life would end? And the Supreme Court said, yes, a person does have that ultimate right of self-determination. But in order for someone to carry it out, there needs to be clear and convincing evidence of a patient's wishes to withdraw life-sustaining medical treatment. We just, in this case, the Cruzan said, well, we know, and Nancy had expressed this to us, but there was no document that said that. And so this, in 1990, defined the need for written documentation as evidence of an incapacitated patient's treatment preferences. So the Supreme Court said, yes, you can do it. You can withdraw life-sustaining medical treatment. And yes, the patient has other rights of self-determination, but there needs to be some clear documentation of it that provides clear and convincing evidence. So back when Congress passed laws, they passed quite soon after this, passed a law called the Patient Self-Determination Act of 1991, which helped to implement medical advance directives and end-of-life living wills. And what it said was any hospital receiving federal funds, receiving Medicaid and Medicare care, so just about any hospital, was required to ask patients if they had an advance directive on admission, document it, and follow them, and have written policies for implementing advance directives. And so that became the origin story of advance directives. And so in the 1990s, states began to adapt advance directives for mental health purposes because they hoped that they could strengthen patient self-determination and reduce the use of involuntary commitment. One difference between PADs and end-of-life advance directives is that they're generally self-binding. That means that the patient or the person who writes a PAD in most states generally is saying, no matter what I say, if I'm incapacitated, follow this plan. Don't follow what I say when I'm in acute crisis. Follow what I write down or follow what the healthcare agent says are my preferences. So by self-binding, it means that once incapacitated, the patient can't change his or her mind about treatment preferences. And this is a controversial aspect about psychiatric advance directives because there are some people who would like an advance directive but don't want it to be self-binding. So in the late 1990s, a bunch of states, including North Carolina, passed the special PAD statutes. In North Carolina, it became two pieces of statute. One was called Advance Instructions for Mental Health Treatment, where the instructions themselves were documented, but the other was to add to the healthcare power of attorney that existed already, the ability to appoint a healthcare power of attorney for mental health reasons. So you can see here the progression of states who passed these specialized psychiatric advance directives. So separate from their advance directive laws. And you see it started in the 90s with Minnesota, Arizona, Maryland, Oregon, and Maine, and has progressed across the states, leading most recently Nevada to passing one in 2017, and very recently Georgia to passing one, a freestanding psychiatric advance directive statute in 2022. So there's been a fairly steady progression so that you now have 28 states that have these psychiatric advance directive statutes. So one of the questions people ask is, do patients actually want to complete PADs? Is this just something, a figment of the imagination of advocates? Or when you ask people with mental illness whether they actually want one, do they want one? And we did a survey through the MacArthur Research Network on mandated treatment some years ago, 2004, in 5 sites: Chicago, Durham, San Francisco, Tampa, Florida, and Worcester, Massachusetts, and asked patients in mental health clinics, do you have a mental health advance directive, or have you appointed a healthcare agent for future mental health treatment? And you see here that a very low percentage had actually gone ahead and done one on their own. So except for the one outlier, which was Tampa, about 4 to 5% of patients who were in treatment at mental health centers had actually done them. But then we asked another question: would you want to complete a PAD if someone showed you how and helped you how to do it? And you see then that about 2/3 to 3/4 of patients in aggregate said, yes, if someone helped me to do this, I would really want one. Incidentally, in subsequent studies that we've done, in which we did offer to help people, we have found that consistently, if offered help, and we've done randomized trials of this, in which one group was offered assistance and one was offered just a brochure or a video on how to do it, we found that about 2/3 or 3/4 of people actually accepted the help and completed a valid psychiatric advance directive. And by valid, I mean one that would have the legal force of it and could be implemented and enforced. So you see from this that actually there's a big latent demand. There's a large demand among people with mental illness for psychiatric advance directives, but very few are going to do it on their own. And we took from this that we really needed to figure out how to provide effective assistance to people with mental illnesses to actually complete them. So a way to help them do it. And since this time, we have done a number of studies that showed that we can help people do them, and they can be done by our research volunteers, by clinicians, by peer support specialists, by members of ACT teams, and that when we do them that way with that kind of assistance, the patients are satisfied with them. They think that they do embody their wishes, and they're pleased with the outcome. The outcome being that they have this document to file. So why is this important? Why is this of value to people? Well, it allows families and proxies to speak directly with providers during crises, because once it's activated, once someone determines that a person's incapacitated, then the healthcare agent can speak directly to providers through a limited waiver of confidentiality. And it also allows them to help make decisions during crises. And clearly it supports patients' autonomy and empowerment. And we have found that patients who do them feel that empowered by having one, and feel more of a treatment alliance with their providers, knowing that they have this document in place or this mechanism in place. We think it can reduce involuntary treatment, improve continuity of care by conveying information effectively during a crisis. And they're also important because honoring a PAD is a condition of participation in Medicaid and Medicare for treatment facilities under the Patient Self-Determination Act, which I discussed, briefly a few minutes ago. So again, typically a PAD has two parts, and it does have two parts in other states. It has the advance instructions, which are similar to a living will, except they cover psychiatric content. So it documents the wishes, consent, or refusal of future care. So it can do any of those things. And then the separate second part is a healthcare power of attorney, which appoints another person to make decisions during crises and can be designed to have broad or limited powers. In North Carolina, you can have either or both. In some states, the process involves only one document that has those two components. So what the instructional directive does is it usually permits an individual to plan for, consent to, or refuse things like hospital admission, medications, even electroconvulsive treatment or other treatments for mental illness. But one thing that needs to be clear, that it takes effect in the event that the individual loses the ability to make decisions. So it takes effect when the patient's deemed incapable. It doesn't have legal effect other times. It can provide guidance, and it can be helpful to providers to know what a patient's preferences are, but it doesn't have legal effect until a patient's been deemed incapable. So how does one do that? And we'll get back to the issue of incapable. So any person can make an instructional directive as long as they are of sound mind. So at the time that they do it, they can't be already deemed incompetent or deemed incapacitated. And they have to a witness, appear to be of sound mind, which is the same standard used for something like a will, where when you write a will, your witness is attesting to the fact that you're of sound mind. And then it's signed in the presence of two witnesses. And those witnesses can't have a conflict of interest. They can't benefit potentially from the instructional directive. So it's not a person, not a relative, not a healthcare provider, not someone in the staff of a facility in which the client's a patient. And then typically there are these, in addition to the two witnesses, it has to be notarized, and then it's presented to the doctor or mental health treatment providers, put on the chart, put on a registry. It's put wherever the patient desires. So what does this term incapable mean? Because it really is the linchpin of the activation of, in your case, the healthcare power of the healthcare agent's authority. And the definition in Wisconsin is that incapacity means the inability to receive and evaluate information effectively, or to communicate decisions to such an extent that the individual lacks the capacity to manage his or her healthcare decisions. And that's in Wisconsin, Chapter 155. So the person's unable to receive and evaluate information effectively, or to communicate decisions to such an extent that the individual's judged to lack the capacity to manage his or her healthcare decisions. And that is based on an examination done by two physicians who agree that the person lacks capacity. It can be one physician, a psychologist. It can be one physician and a nurse practitioner or a physician assistant. But two providers have to document in the chart, in the medical record, that the person lacks capacity. And at that moment, when that's been written down in the medical record, the person no longer has capacity and shouldn't be making any healthcare decisions until they've regained capacity. Now, let me be clear that incapacity is different than incompetence. Incompetence is something that a judge decides. A physician will provide maybe an affidavit, or there may be other type of testimony, and the judge then evaluates that evidence and determines whether the person is incompetent to make a certain type of decision, and then may appoint a guardian to make those decisions on the part of the individual. So this is not a court process. This is an informal clinical process whereby two physicians say this person shouldn't be making or shouldn't be allowed to make treatment decisions, and a proxy needs to stand in. So does that mean that the clinician has to honor these instructions that are given by the healthcare agent? And in Wisconsin, it says that the clinician's not liable for disregarding instructions that are given by the healthcare agent, as long as he or she attempts to refer the patient to another provider or facility that might honor the wishes of the patient. So let's talk a little bit more about the power of attorney for healthcare. It allows a patient to appoint someone to make treatment decisions when a patient is incapable, and we've just said what that is. It can be combined with instructional directives in other states, but not in Wisconsin. Because in Wisconsin, the declaration to physicians is limited to end-of-life decisions. But any capable adult may execute this power of healthcare. So who can serve as a healthcare power of attorney? Any competent adult, 18 or older. The individual can't usually be providing healthcare to the person. And the person doing this is encouraged to name several people to serve in that capacity if the first person on the list is unavailable. So it allows for a circumstance where maybe the first person who's named is out of town or is ill or not able to speak to the situation. It only takes effect, again, when the person's found to be incapable and continues during that period of incapacity, which is usually determined by two physicians or a physician and psychologist who write and document the patient is incapable in writing. So what powers and limitations does the power of attorney healthcare have? Well, they can make whatever decisions the patient usually could make, unless the patient limits the authority of the healthcare power of attorney, or in your case, the healthcare agent. And the patient can instruct the healthcare power of attorney on decisions about medications or other treatment decisions. However, and this is a big however, in Wisconsin, the healthcare agent may not consent to admission of the patient, in this case of the principal, to an inpatient facility that is either an institution for mental disease, an intermediate care facility for people with intellectual disability, a state treatment facility, another type of mental health facility. A principal may be admitted or committed on an inpatient basis to a facility only under the applicable requirements of Chapter 51 or 55, which that really means only if the person, if they can't consent, has to be involuntarily committed. And in addition, the healthcare agent cannot consent to experimental mental health research or psychosurgery or elective convulsive treatment or drastic mental health procedures, however those are defined. So that Wisconsin restricts the authority of the healthcare power of attorney to, or the power of attorney for healthcare in your case, to decisions, so they can make decisions about treatment, but can't admit the person voluntarily to a hospital, a psychiatric hospital or similar thing, can't authorize research on the person, psychosurgery, can't authorize electric convulsive treatment or other types of so-called drastic mental health treatments. And this is according to Wisconsin Chapter 155. So how does a person revoke this? The principal, the patient, may revoke his or her power of attorney for healthcare and invalidate that at any time, any way they choose to. So if they want to say at any time, I don't want this thing, they can rip it up, they can take it down from where it is, however they want to, they can remove it. The statute says that the only time they can't do that is when they're incompetent. So it says here, if a principal after executing a power of attorney for healthcare is adjudicated incompetent in the state, the power of attorney for healthcare remains in effect, except that a court may, for good cause, revoke the power of attorney and invalidate the power of attorney for healthcare instrument or limit the authority of the agent under the terms of the power of attorney for healthcare instrument. So it doesn't say that, as far as my reading, that an incapacitated patient can't revoke it. So it only says that an incompetent patient can't revoke it. And generally, these things stay in effect until a person revokes them. So why aren't these in the mainstream? Why aren't PADs everywhere? Well, for one thing, these are state laws. They're not federal laws. And some states haven't been sold on the benefit of PADs. And there hasn't been really focused advocacy for them in the states that don't have them. And 28 states have them. Another reason is that they're hard to complete. And we don't think that many patients are likely to do them without assistance. And that assistance often is not available. Sometimes health systems and providers need guidance in putting PADs into practice, and providers need education about PADs. So there isn't a sort of groundswell in the states that have them on the books, they're not used that much, and it hasn't created as much advocacy as you might like to have PADs in every state. So in North Carolina, if someone has one and they want to put them in a directory, they can go to the Secretary of State in North Carolina and put them on file there. Most people put them in the electronic record of the health system that they're affiliated with, or they can just give them to the doctors and the hospitals that they work with. So if you want to read more about this, or you can go to our website at the National Resource Center on Psychiatric Advance Directives, nrc-pad.org. But you can also read a lot about this in any of the major advocacy organizations like NAMI, Mental Health America, the Bazelon Center, or the Crisis Navigation Project is listed here. So let me stop there and we can talk about it.